Oh, oh,
Yes, go on.
okay. This is very, it's a very didactic case or a very educative case in order to understand the usefulness and the utility of this pot balloon in a real world case of acute coronary syndrome. So this was a 59 years old male that arrived in my hospital with an acute myocardial infarction. We can see here for the first angio that the patient has an occlusion, an acute occlusion of the right coronary, but above all, we see that we have some coronary ectasia. So is an aneurysmatic disease of the coronary arteries. But the acute myocardial infarction is not the topic of this presentation. We can see from the angiography, diagnostic angiography, that there was also a disease at the level of the proximal LID, at the level of the bifurcation of the proximal LID. We can see here that the patient had also disease at the level of the first diagonal, an important first diagonal branch, and with kind of secondary bifurcation of the diagonal. So a disease at the level of the bifurcation with another branch of the first diagonal. But above all, we see that from the diagnostic angiography that we have an aneurysmatic portion and some ectasia even at the level of the proximal LID. So this was my first concern about the treatment of these patients. So the aneurysmatic disease, it's not so easy in terms of correct apposition of the drug-eluting stent. So this was the treatment during the acute myocardial infarction with an implant of very big drug-eluting stent, very large, so Megatron that were expanded, IBUS guided with a big balloon. And this was the final result with an IBUS optimization at the level of the distal and proximal right coronary. So after the index procedure, I mean the culprit lesion, we planned during the same recovery the treatment of the LID bifurcation. And this was the scenario. We can see here, well, this disease at the level of the bifurcation and the disease at the level of the bifurcation of the diagonal. So I think this, of course, is a Medina 100 bifurcation, but I had some doubt about the possibility of some disease at the level of the ostium of the ostium of the diagonal. So, okay, this was the scenario. So proximal LID with tight stenosis, no disease at the level of the medium LID, and some maybe angulated origin of the diagonal with disease at the level of the diagonal of the bifurcation of the diagonal. So my strategy was, first of all, to do a sort of preparation of the LID and of the diagonal in order to perform an IBUS interrogation with more stability without any ischemic problem, in order to understand better the anatomy of the bifurcation and the anatomy of the diagonal branch. So I decided to prepare the LID with a 2.5 non-compliant balloon and the diagonal branch with very, very long preparation with a 2.5 non-compliant balloon in order to evaluate the result of after a balloon treatment of the diagonal branch. And this was the IBUS interrogation, of course. And we can see here the result or the analysis. We can see here at the level of the mid-LID and healthy vessel, we can see a very clear minimum disease or healthy vessel, and this was my landing zone. We can see at the level of this diagonal, a small diagonal, and the first septal. We can see here at 6 o'clock and 12 o'clock the two small branch. And the diameter, so the main vessel distal diameter was, as you can see here, very, very precise, a 3.5 vessel diameter. And this was the disease at the level of the mid-LID, very, very tight and calcified stenosis, concentric stenosis. We can see here the shadow, echographic shadow of the calcium, a concentric but very, very short calcified lesion. And in this picture, we can't see the ostium of the diagonal, but the ostium of the diagonal has not significant disease. After this picture, we can see better this aspect of the diagonal. And above all, we studied very well the proximal part of the LID at the level of the aneurysmatic or ectasic portion of the LID. And this was the picture. We can see here a big vessel and very short part of this vessel with this big diameter. And the diameter was 4.5 or something more. 4.5 was the reference diameter of the proximal landing zone of the stent. So 3.5 and 4.5, but very, very short segment of disease, so focal disease. So my strategy was, of course, in case of Medina 100, to perform a classical provisional stenting, so prepare the lesion with a non-compliant balloon and implant a drug-eluting stent across the side branch with a diameter sized according to the distal main vessel diameter. After that, to perform the POT optimization post-dilatation and to do a rewiring using the pulling back technique as recommended from the Bifurcation Consensus, or sometimes we can use a dual lumen microcatheter. And after the rewiring, to perform of course, a kissing balloon, and after the kissing balloon, a report. During this procedure, my idea was to evaluate the result of the diagonal branch, and in case of good result on the diagonal branch, to treat the secondary bifurcation with a drug-eluting balloon in order to keep easy the procedure. So this was the aggressive predilation of this calcified lesion. We know that if we have a very short calcified lesion, and even if this calcified lesion is thick with thick calcium, but if it's very short, a sort of diaphragm of calcified lesion, we can treat and we can achieve good result with non-compliant balloon at high atmosphere, of course, with diameter matched with the vessel diameter, and we can crack this diaphragm and the calcium only with non-compliant balloon. In case of low calcification, the strategy, of course, is completely different. But if we have a very calcified and tight lesion, we can achieve very good cracking of the calcium only with non-compliant balloon. So we use 3.30 balloon and 3.5 in order to be safer. So go step by step. And after the predilation at this level, at this concentric focal lesion, this is the balloon, non-compliant balloon, the 3 and next the 3.5. We decide to implant the stent, according to with the bifurcation consensus document, we follow the 3 diameter rules. As Gabor told, we implant a drug-eluting stent across the side branch with diameter correctly sized with the distal main vessel diameter, and after that we planned to do a pot and a final kissing balloon with the diameter of the pot matched with the proximal main vessel, and the kissing balloon with the diameter of the balloon matched with the diameter of the side branch and with the diameter of the distal main vessel. So following the bifurcation consensus recommendation. So this was the drug-eluting stent exactly implanted in the distal, at the level of the distal landing zone where the vessel was healthy. We can see here the level of this small, at the level of the septal branch, and exactly implanted at the level of the aneurysmatic portion, because it was very short. So 3.5, 12 millimeter. And this was the shape of the drug-eluting stent before the pot. And we can see here that the stent was very precise in the position that we checked by IBUS, and the wire of the diagonal, the jailed wire, was exactly in the mid of the drug-eluting stent, at the mid in terms of length of the drug-eluting stent. So now it comes the pot. So I repeat, the pot should be performed with a short balloon, and we have to consider an extra 6 or 8 millimeter in terms of length more than the stent length. We should use, of course, a non-compliant balloon, and we have to consider the shape of the balloon that we use, above all the length of the shoulder, as Pablo and Gabor told you. So the pot balloon from BrosMed is ideal for this technique. And the other point is the position of the pot. We can see here that the incorrect placement of the balloon is associated with suboptimal result. We can see here that if we place the balloon too distal, we can create a kind of a stretch of the distal main vessel. If we put the balloon too proximal, we can create some dissection of the proximal main vessel. Above all, if we have a short bifurcation, or in the second problem, I think we have an incomplete expansion of the side branch ostium. I mean, the strut opening is not perfect, and this could create some problem when you have to rewire the ostium of the side branch. And the opening of this strut is crucial, because when you have to complete this technique with the second stent, the opening of the strut is useful to cover part of the ostium and to reduce the protrusion of the second stent inside of the main vessel. So the opening of the strut when you perform the pot is another aspect very important. So the pot helps a lot to perform this part of the provisional stent. So this was the shape of the stent before the pot. We can see here the position of the pot was exactly at the level of the carina, because the pot was is a balloon with a short shoulder, and the length of this balloon was perfect, because the stent was 12 millimeter and the pot was 6 millimeter. So even with the length, we were sure that the position was correct. And you can see here the shape of the pot balloon without shoulder and exactly at the level of the carina. And what is very interesting, I think, is the shape of the drug-eluting stent after the pot. We can see a clear mismatch of diameter and clear and above all very, very precise mismatch of the drug-eluting stent in the portion overexpanded with the pot balloon and in the portion more distal where the diameter was 3.5 millimeters. Even changing projection, we can see that we have this very, very nice shape of the drug-eluting stent. Nice because was matched with the anatomy, complex anatomy of this bifurcation. And what is very interesting is the IVUS analysis after this, after the pot, because I was interested to understand how was expanded the stent respect of the aneurysmatic portion. We can see here the perfect apposition of the drug-eluting stent according with the IVUS analysis, 3.5 on 3.5 at nominal atmosphere, 3.5. So this was the distal landing zone. And this was the level, the analysis at the level of the bifurcation. And we can see here a very good apposition at the level of the bifurcation with some eccentric calcified plaque, but good opening, good apposition of the drug-eluting stent. And this is, as you told before, the ostium of the diagonal with no disease. So the curve and the angulation of the diagonal was the reason of this shape, but with no disease. We can see here the diagonal and the LID. And we can see here this imaging was an eccentric calcification of the plaque, but very eccentric at the level of the bifurcation. So I decide, and above all, the analysis at the level of the ectasic portion was very, very good. We can see here the stent before the bifurcation. This was the diameter, exactly 4.5 millimeters at this level, and even more proximal. The result was very, very good. So the apposition of the drug-eluting stent at the level of the aneurysmatic portion was very, very good. We had this sort of calcification, eccentric calcification. We decided to optimize this eccentric calcification using a 3.5 balloon and at very high atmosphere. But even the result was good before this predilation, but was kind of optimization. And we can see here the different shape of a non-compliant balloon with a length of 8 millimeters with the pot. We can see it's totally different. Even the length is very similar, 8 millimeters and 6 millimeters, but the shape is very different. And we can see here the shoulder very long. So this is the problem that Gabor and Pablo told you. The shape of the balloon when we consider to perform a precise post-dilation, it's crucial. So after that, I show you some beneficial effect in terms of procedure, in terms of technical step of the procedure. The first is the very easy rewiring using a normal workhorse, the same workhorse using the pulling back technique. We can see this is a normal workhorse with the same shape I used for crossing the LID, and this is a real-time crossing at the level of the distal strut, so something like 50 seconds, and the wire crossed very easily the distal strut, we can see here. And next I had maybe some problem with a kind of a small dissection in the mid part of the LID where I treat with non-compliant balloon. So, but with some gentle rotation, the guide wire went very easily. So after that, I decide to treat with a drug-eluting balloon the bifurcation of the diagonal, because the result after non-compliant balloon was very good. And this was the crossing of the non-compliant balloon toward the strut of the drug-eluting stent without any opening, without any predilation. So this was very interesting. I do this intentionally to evaluate how was correct my procedure, my opening. And you know that drug-eluting balloons are not the best in class in terms of crossability, but we can see here that the drug-eluting balloon crossed very easily in this distal strut because the technique was correct, the post dilation was correct, and the opening of the distal strut was correct. So this, I think, is very teaching. So after that, I performed my treatment with drug-eluting balloon at the level of the diagonal. And after that, of course, I performed the kissing balloon using 3 balloon and 3.5 following the 3 diameter rule. Of course, and after that, I report with the same balloon. And we can see here the shape even also very good, and we can see here another confirm of the correct crossing of the second wire in the distal strut. So the first wire is the jailed wire, and the second wire was the wire that crossed in the distal strut. And so this another confirm of the good technique of this provisional stent. And of course, this was the final result, very good, even in the diagonal branch with the drug-eluting balloon at the level of the ostium and in the proximal part. So my conclusion is, of course, as we told, the pot balloon is very, very useful, is very precise, allows to optimize the position of the drug-eluting stent at the level of the bifurcation, at the level of the proximal main vessel, and also if you perform a correct pot, the use of the pot balloon make your life easy during the bifurcation technique. Thank you.
Thank you very much, Delio. I think it was a very quite simple solution for a very complex case, and you very beautifully show us how intracoronary imaging is very important and how you can go step by step and solve a very difficult situation with really one stent and one drug-coated balloon in the end. So that's great result. Thank you. There's one question from the audience. So the question is, I think it's a good question. So is the kissing balloon inflation mandatory when you do POT? Or you can just do POT and forget about the branch? In which situations you do POT and then kissing and repot, and in which situations do you just end the case with the final POT?
Yeah, I think the kissing balloon is mandatory when the side branch is an important side branch, and when we think that we could recross or we could retreat this bifurcation in future. If we have a small side branch, so less than 2 millimeters, I think the strategy is the correct strategy or the reasonable strategy is to keep it open and perform the pot in order to optimize the apposition of the strut toward the side branch, but I think the kissing balloon, it's not mandatory. But if we have a side branch with big diameter, with big territory in terms of perfusion, I prefer to perform always kissing balloon, and after kissing balloon, report.
Okay,
this is my
so keep it open, that will be the message. A question from my side. We show you your beautiful images of stent enhancing. Do you trust the separation of the wires as the marker to put the distal marker, or do you inject and use the angiogram? Because I will maybe rather use angiograms if you are not really orthogonal to the bifurcation. What are your thoughts?
I use both. I have not a rule about that. If I see very well with I use a lot the stent magnification. I mean the clear stent or stent boost to understand the anatomy and the position of the drug stent and the position of the pot, as I showed in the presentation. But if I don't see well, I use check with contrast. I agree with you.
Okay.
Because the projection, the anatomy sometimes is not clear, and it's not enough to understand where to put the marker of the pot. Yes.
Okay. Thank you, Delio. So I would like to now go to the summary and closing remarks. I think we had today a very nice webinar. In the introductory talk, we learned the rationale and technology behind this balloon. The first talk described the principles of POT, or how to adapt distal stent size to the proximal vessel size at a bifurcation. Stents also usually elongate, as Dr. Toth beautifully showed us, and you have to know your stent platform to know its overexpansion performance. In my talk, I talk about how BrosMed balloon helps to make results predictable in precision PCI on the most complex cases, such as calcified disease, and also two-stent strategy, which is now turning into dual kissing strategies, but also more important, triple pot strategies. And in the last talk, we revisited the strategy which will work for more than 80 or maybe 90% of bifurcations, and it is a provisional stenting. Dr. Tedeschi showed us step by step a provisional and pot strategy. And remember that this is more a philosophy of starting with just one stent rather than a definitive strategy, and the door is open for a second stent implantation as a bailout. Michelle, maybe you want to say a final word, and then we will adjourn this session.
Okay, thank you. Thank you for all the experts sharing, and thank you for the support for POT balloon and BrosMed, and we will keep moving. Thank you.
Thank you.
Thank you, Michelle. Thank you, BrosMed, for facilitating this webinar. Bye-bye, Delio. I had to leave a little bit earlier. Bye, Jenny.
Bye.
Thank you all for listening.
Bye. Thank you.
Thank you.
What is POT? The Proximal Optimization Technique, POT, has been proposed as a strategy to improve the results of stent scaffolding of bifurcation lesions. It is a straightforward technique whereby a short, appropriately sized balloon is inflated in the main vessel just proximal to the carina. The POT-PTCA balloon dilatation catheter is indicated for both the proximal and distal optimization technique. The proximal segment of the stent can be evenly expanded to improve stent strut apposition. The extra short balloon shoulders reduce longitudinal balloon growth, minimizing the potential for vessel trauma outside the treatment area. Provides accurate post-dilatation stenting and reduces vessel wall injury. Rated burst pressure up to 22 atmospheres for stent expansion and apposition without any dog bone effect.